Good morning, everyone.
Morning.
Let's just wait till we have quorum here. I'll get going.
We have a couple of fellows doing the in-training exam today, the in-service exam, so they will be joining us.
Okay, thank you, David. And that's right. I totally forgot about that. Okay, so we'll get going then. A couple of slides today. So first, okay, this is a screenshot taken during battery and lead measurements in an ICD patient. So this is a patient who had an implantable defibrillator, and we are basically looking at the data of the battery and lead measurements. So is everything looking okay? Anything to do? We can go through the various lists there. So why don't we start with Tarek? What do you think, Tarek?
Yeah, so I think from starting from the heart rate, I see it on the top left. So looks like 73 beats per minute.
Right.
I think.
What do you think about the sensing in it? Does it look right to you?
Let's see.
And so it has a marker channel, right, where it's telling you. So,
I think so. Yeah.
Yeah, looks good. In fact, there's even looks like there's either a PAC or a PVC here, an early one, but it seems to be. One of the things I'll mention is you notice how large this artifact is which is probably an artifact of the T wave or repolarization. Yet the systems can distinguish between them. Okay, so why don't we go through this list?
So I think from the battery perspective, I think it's good. There is still a long time. And then as far as the battery voltage,
what does RRT stand for? Well, that's just basically the time when it reaches time for replacement.
Okay.
Sort of like the equivalent of the ERI for a pacemaker.
For pacemaker. Okay, and then
so the battery voltage looks good to you, right?
Yes.
Yeah, I mean, the thing about that is every device has a different maximal battery voltage. So you really need to look at what the replacement interval time voltage is. In this case, it's 2.73. And I think this is a Medtronic device. I think about 3.1 is the implant voltage. Yeah.
Okay. And then, so as far as the last charge, so the charge time, like it mentions 3.8. So I think maybe it should be a little higher, no?
Well, is a long charge time better or a short charge time better?
A short.
Right. So basically what they're saying is you have to really know what the charge time is for a particular device, but anything under 10 seconds is probably an acceptable charge time. Okay. So what do you think about this? Do you have any idea what this short VV interval thing is? You may not know because it's not that intuitive. You have any idea?
No, not really.
So when there are problems with a lead, what can happen is that there's noise on the lead, and the defibrillator company is smart enough to know that to know this. And so there are a number of algorithms looking for VV intervals that are so short that they're not even associated with physiological arrhythmias. And so the reason they include this is that sometimes it can be a sign of a problem with the lead, but more often it could be a sign that the lead was not properly placed into the header of the device, and there's a looseness there. And you can see a lot of short VV intervals. I think when there was a lead called the Medtronic, what's the name of that? Sprint Fidelis lead, which ultimately was taken off the market, which had a lot of problems with its insulation. We were told to put on alarms for short VV intervals. That was, if you saw a lot of short VV intervals, that was usually a sign that the lead was about to go. Okay, so what do you think about go ahead, I'm sorry, I apologize.
No, sorry, Dr. Price.
And what about the pacing impedance? What do you think about that?
So I think that's appropriate. So usually if it's really high, that means we have to suspect like a lead fracture.
Right, so really high or really low would be bad. So above 300 ohms is usually an acceptable pacing impedance. And the most important thing about impedance is looking at the trend of it. In other words, if it was 600 and now it's 360, that would be more worrisome than if it's always been around 360. So in this case, I can tell you without showing you the trend, it was always between about 350 and 390. So 360 is fine. What about the defibrillation impedance, 61 ohms?
Say
hard to
that's
know.
probably
Go ahead, I'm sorry.
So also maybe it's a trend too.
Yeah, it is a trend. You're absolutely right. And it's kind of an unfair question. So I apologize for putting you on the spot with that one. But basically, every device is different in this regard. But I think in almost every device, this would be considered a shock impedance that is in an appropriate range. I think basically anywhere between about 40 and 80 or 90 is probably okay. And then the R wave amplitude in this case is 19 millivolts. So what do you think about that? Is that an adequate R wave?
I think so.
Right. So do you have any idea what the minimum acceptable R wave would be? Let's say you're in the cath lab and you're putting a lead in, and the representative of the company who's standing by the PSA says the R wave is X. What number would not be an acceptable one?
So maybe less than 10.
Actually, less than 4.
Less than 4.
4 is like sort of generally. Now, if it's a chronic lead that's been in for a while and it's always like 3.8 or something, we'll usually accept it. And remember that when we program defibrillators, we set the sensitivity at like 0.3. So if it's 3.5 or 4, we still have a 10-fold safety margin in terms of sensing. But generally speaking, you would not want to start with an R wave of less than 4, because it could go either way, right? It could get better and become 6 or 8, or it could also go down. And what was 4 at implant could be 1.5 in follow-up, and that would not be an acceptable R wave. So 19 is a very, very good R wave. Obviously, just so we're all on the same page, the bigger the R wave, the better, because it means that the device can sense intrinsic activity easier, right, with a large R wave. So in this case, this is good. And this device was placed in a patient for primary prevention in a patient with cardiomyopathy. So you always like to see a nice R wave in that type of patient, because it means that the chance of inappropriate shocks are lower, because the sensing theoretically should be better. Okay. Very good. Not easy questions. Okay. Some more pacemaker stuff. So you are checking the atrial threshold, and so the threshold is reported here as 0.75 volts at 0.5 milliseconds. You're checking the A threshold. Is this a good or a high threshold? Is the permanent program setting appropriate? And the permanent program setting is 1.75 volts and 0.5. The threshold was 0.75. So what do you think, Maya? Are we in, is this a good threshold or one that would give you pause or concern? And do you think that the operator has adequately programmed the atrial lead at those outputs?
All right, so if our threshold is at 0.75 and we have it set at 1.75, I would think we need to actually increase the voltage a bit.
Well, how much, by how much?
I guess just like kind of going off, I don't know if it's similar to the way we do our temporary pacemakers, but usually we like a minimum of 5.
Well, remember that in temporary pacemakers, we're programming the amperage, but we're not programming the voltage. So that's different. You have to have both, but in temporary pacemakers, we only have control over the amperage. We don't have control over the voltage, and we don't have control over the pulse width. In a permanent pacemaker, we program the volts and the pulse width, and just get a current that is dependent on those two features. So what do we normally say? If you're at the bedside and the threshold was 5, 5 milliamps, what would you set the pacemaker at?
You would want to set it to twice that much.
Right, so you'd set it at 10. The same thing goes for permanent pacemakers. So when you see an output or a threshold of 0.75 at 0.5 milliseconds, sort of a bare minimum acceptable output would be 1.5 volts at 0.5 milliseconds. So this person has programmed it at 1.75. Now, if you look at the literature on pacemakers, it turns out that programming at less than 2 volts has very little impact on the longevity of the battery. Some people would say that from a safety and battery perspective, you may as well leave the patient at 2 volts, even though 1.5 or 1.75 are an adequate threshold safety margin. But I have to say that for me, when I'm programming an atrial pacemaking lead, particularly in somebody who does not have sinus node dysfunction, I will often, if the threshold is this good, and anything under 1 volt is considered a good threshold or a low threshold, I would sometimes program it less than 2 volts on the theory that anytime we reduce the expenditure of pacing in a pacemaker, we can get better longevity to the device. I'm less willing to do that on the ventricular lead, where if you have a patient who has heart block, we really don't want to ever have non-capture. So my own personal bias is that for ventricular leads, I never go below 2 volts, even if the threshold's very, very low. Or at least I try not to. But in the atrial leads, if the threshold is this low, I might leave a person at 1.5 or 1.75. So again, just to remember, the pulse width is how long the energy is being delivered. And in the bedside pacemakers, we do not have control over the pulse width. Just so you understand, the pulse width on those devices is in the range of about a little less than 2 milliseconds. So it's about 4 times the pulse width of this device. So you can see that whoever designed those was cognizant of the fact that temporary wires don't have great contact with the heart. So it's very jazzed up with a lot of energy, a lot of the longer you deliver the energy up to a point, the lower the threshold, the less energy you will have to deliver to capture the myocardium. In other words, if I had set the pulse width in this test to 1 millisecond instead of 0.5, the threshold might have been 0.25 volts. But longer, in general, more voltage is a bigger battery use than pulse width, but a long pulse width is also a battery drain as well. So in a perfect world, we would like the pulse width in a permanent pacemaker to be in the range of 0.4 to 0.5. And we would like the amplitude to be 2 volts or less for the output. that would be the best setting. Some of you may have heard me say in clinic, it's very interesting, so here we measured this threshold and we have 1.5 and 0.5, 1.75 and 0.5 as our output. Turns out that when they've done a lot of studies over the years of patients who've died and they've interrogated the pacemaker to get the setting. Turns out that like 95% of patients who have a pacemaker die with the original settings that come out of the box from the manufacturer. That, in other words, whoever was managing the pacemaker never changed the outputs or the sensitivity. And that's unfortunate. I think it reflects the fact that, particularly in the adult world, there's oftentimes interventional cardiologists will put pacemakers in patients, even though they may not be as well versed in electrophysiology. And but if you leave the device, the in-box outputs are usually 3.5 volts and 0.5 milliseconds. So basically, in a patient like this, you would be pacing at 4 or 5 times the output. And so you would use up the battery more, and the need for a generator change would be greater. These types of changes, lowering it down, particularly for the ventricular lead in a person who is pacemaker dependent, can literally add 3 to 5 years of longevity to a pacemaker, depending on how much the patient uses it and what their threshold is. So it's quite important to make these assessments, particularly for pediatric patients who are going to need lifelong pacing. It's one thing if you're putting a pacemaker in an 87-year-old person, where if you got 10 years out of it or 6 years out of it, you might be reasonably pleased with that result. In a pediatric patient, we want to lengthen the lives of every pacemaker so that by the end of life, the patient has had fewer pacemaker surgeries. Because remember that every single pacemaker surgery carries risk of infection, and the infectious risk grows with every pacemaker generator change. Similarly, every single time we take the pacemaker out of the pocket and replace it and manipulate the lead, there is a chance that we can injure the lead. Because some of you who've seen these cases with me and with Barry, I'm sure have noticed that oftentimes the lead is encased in a lot of scar tissue. And so we have to do a lot of dissecting of the lead. And though we try to be very, very careful, you could imagine that the risk to the lead is not nothing every time you take it in and out. So if we can reduce the exposure of the device and the lead to people like myself or Barry, that's to the patient's benefit. So we're always looking at ways to sort of squeeze the orange as much as we can to get as much juice out of it. Is that okay? Everybody get that? Okay. All righty. This is a patient who has a biventricular ICD. It's DDD paced. And we're going to go through these numbers here. So we see that the remaining longevity looks good with an average of about 6 years. And, it's important to remember when we're telling patients these data, they need to understand this is not 1,000% accurate. It can be off. And in fact, Medtronic is hedging their bets and saying it's anywhere between 5 and 7 years. The battery voltage is 2.99 volts, with the replacement one being 2.73. And it's important to remember that these voltage curves are not linear. In other words, if the device were 6 months old and you knew it was 3.0 at implantation and it's now 2.99, it's actually, you cannot actually predict when you're going to hit 2.73. It doesn't work that way. They tend to stay the same and then they sort of fall and then they fall. So all the voltage tells you is if we're okay. If we're very, very close to the replacement voltage, that's useful information. Otherwise, it's kind of unhelpful as long as it's in a reasonable range. Again, we see a charge time at 3.8 seconds, suggesting a fresh battery. We see no short VV intervals. That's good. That means that the device doesn't have any lead integrity issues. We're looking at the impedances of the atrial, RV, and LV leads, and they are all reasonable impedances. You notice how much higher the impedance of the LV lead is from the other two. That's just typical of these very small small coronary sinus LV leads, very, very common. And then the shock impedance or the RV defibrillation impedance is 58 ohms. You see here that there is an SVC defibrillator impedance and it says none. That's because there are two types of defibrillator leads. There are leads that are that have a single coil, meaning that there is just one shocking coil at the end of the lead. And then there are leads that have a shocking coil at the end and a second shocking coil that is a couple of inches proximal to it, usually ending up in the SVC or the innominate vein. And so the theoretical benefit of a lead that has both of those coils is that on average, it's expected that the defibrillation threshold or the amount of energy required to defibrillate someone would be lower if you have more shocking vectors. Turns out that the difference is very negligible in most patients, and SVC coils can become very heavily scarred, meaning that when it's time to remove a lead or extract it, the presence of a second coil makes the extraction much more dangerous. Where is the most common place that when there are disasters during a lead extraction, where is the most common place that injury occurs, David?
Trying to remember.
So
I know that it's a very dangerous procedure, but is it the RV?
It's actually in the innominate vein in the SVC. That's where most of the really bad injury. I mean, let me stay at the start. You can have a terrible injury anywhere. It can be at the RV. You can evert the RV. You can injure the tricuspid valve if the lead is very adherent to the tricuspid valve. So it's very common that after an extraction, there's a little bit of TR that wasn't there before. But the most serious, dangerous problem is if you have a tear in the SVC or the innominate vein. And that is the most common area where you have a disaster from. Because in the process of trying to get it off of that vein, you can tear it and you can have uncontrolled bleeding. One of the ways in which we protect against that has been the development of these very, very large balloons. So I don't know if any of you have been involved in any of the extractions. Barry very rarely will do one with assistance from our adult colleagues. And so if the lead is attached to the SVC or the innominate vein to any significant degree, we will sometimes put up this gigantic soft balloon and the theory is that if the vessel were to tear, you could inflate the balloon and tamponade the tear temporarily while getting surgery to come in and open the chest and repair the tear. That has markedly reduced the risk of dying during these procedures, but it is a very, very dangerous procedure. Again, 99% of the time it's safe and there aren't problems, but about a little less than 1% of patients actually die during extractions. So anything we can do to reduce the risk of an extraction at any time in the patient's life is something we obviously would want. And so, both Barry and I would say it's probably true for almost all electrophysiologists, try in the present era to not put leads in that have SVC coils, unless you have a very old patient in which you have no expectation of ever extracting the lead, and maybe you're worried about the defibrillation threshold and you need more energy, or you're worried it's not going to work. In those cases, you might consider putting in a dual coil system. But in this case, there is no SVC coil. Here we see that the P wave is 3.3 millivolts. So Dave, is that a decent P wave? We just talked about what a good R wave is, which we said should be over 4 millivolts. What about P waves?
Yeah, I think that's okay. I know that we had said in the past we don't set it less than 1.2 millivolts for the sensitivity, so that would be less. One would be less than half of 3.3. So I think it's okay.
That's a good logic there, like that. Yeah, I mean, basically, I think anything over 1 millivolt would be considered a decent atrial atrial or P wave or recorded by the device. You'd rather it not be much smaller than that, because in order to sense something smaller than 1 millivolt, you'd have to make the device very, very sensitive, and you would run the risk of oversensing possibly far field ventricular activity or any kind of noise in the body. So the bigger the P wave in general, the better. So 3.3 is actually a very nice sized P wave. That's really a good sized P wave. And then the R wave amplitude, it says there's no data. So I'm going to ask you, I'll bother David one last time. Why is there no data on the R wave? It gave us a beautiful P wave amplitude. And if you remember our last patient, we had a nice R wave amplitude in this primary prevention ICD. In this patient with a BIV ICD that's DDD paced, why do we not have an R wave amplitude?
I'm wondering if it's because of the biventricular pacing that's making it difficult to determine what the amplitude would be.
I see. That's an interesting theory. That's actually not correct, but it's a good idea actually. No, it's because the patient is paced, right? So when a patient is paced 100% of the time, the system can't measure the R wave because it's not going to measure the R wave from its own pacing. It's only going to measure an intrinsic R wave. And if the patient has not had any PVCs, or alternatively, if the patient doesn't have conduction on their own, it won't have any R waves to measure. So patients who are pacemaker dependent or are paced 100% of the time in the ventricle, whether BIV or BIV or just a single RV lead, the system will have trouble measuring an R wave. Now, when we're in the office, so when I see this, what I will often do is I will try to measure the R wave. And how would I do that, Dave? Let's say, so the patient is paced all the time, and you see here that the heart rate is 61. How could I reprogram the pacemaker temporarily to try and measure an R wave?
You can try to set up like a lower VVI backup, like less than that. So you could try 50 first. And see if you can get an intrinsic R wave, or even, I guess, as low as 40.
That's exactly right. That's terrific. Great answer. That's right. We would change them to VVI. And the reason we would change to VVI is that as long as they're in a DDD modality, it's going to always sense the A and pace the V to it. So if I set the patient to DDD at 30, he's still going to A sense V pace at 60 because the atrium is going at that rate. So you would have to switch it to VVI so that the system does not sense the A, and you'd want to make it very low. And so when we do that, some of you have noticed that when we do pacemaker checks in the office, I'll often ask the patient to lie down, right? And one of the reasons that I do that is, first, the most important is that it's easier to see the electrograms, and the device that's attached to that's outside of the body, the mouse, is not moving when it's, doing the recording and connection to the programmer. But the other reason is that when I do a sensing test, I have to lower the patient's heart rate down pretty low, and sometimes as low as 30 beats per minute. And I don't want patients fainting during that part of the test. And so we have them lie down, and then we lower it down. And so what I'll often do is I'll drop it down to, just like you said, to about 50, then maybe 40, and then to 30. But I won't let the patient sit at 30 for more than about 3 to 8 seconds, because it's very uncomfortable, particularly if you have a normal heart rate most of your life. So I'll just drop it down briefly. And if I do not see an R wave come in, then I just come off and I say that we were unable to assess the R wave. And that's not uncommon in people who have a heart block. Now, most people with heart block do have an escape rhythm, and you can check the R wave. But a patient like this, if we dropped it down and we still had no R wave, we would be, that's important information for when we are doing a generator change, for how long we want to leave the device unplugged to the pacemaker. In the old days, when we used to use a lot of unipolar pacemaker leads, which require that the can be part of the pacing bipole. As soon as you take the device out of the body, out of the pocket, the patient would lose capture because the circuit would be broken. And so if you had a patient who was in complete heart block but had an underlying escape rhythm of 40, it wasn't such a big deal. But if you had a patient who had no escape rhythm, it would be a little scary when you would take the device out. So you would have to be ready to, with your screwdriver, to immediately unscrew the lead and attach it to an external pacemaker temporarily in order to maintain an adequate heart rate during the procedure. So that's the reason why we don't have an R wave. So you will see sometimes when we report the pacemaker checks in the office that the R wave is, we'll put NA next to it because we could not find an escape R wave. Does that make sense? Anybody have any questions about that?
Yeah, what would you set the output to without knowing what the R wave, the sensitivity to, when you don't know what the R wave amplitude is?
That's an excellent question. The short answer is there's no right answer to that. It's a very, very good question. How do you know what to set it at? So what we normally do is we set it at the default of the device, which I think in a defibrillator is 0.8 millivolts, something. I believe that's right. Each one is a little different, but it's usually a little less than 1 millivolt for the V, on the assumption that most of the time when we would put a device, a lead in, we would not accept an R wave that is less than 4 millivolts. Now, you see that in most pacemakers, we set the R wave at maybe 2.2 or 2.8 millivolts, which is a fairly high number of millivolts. That's because we really only need it to be able to sense intrinsic activity. But for defibrillators, we want it to be able to sense not just regular PVCs, but even fine ventricular fibrillation. And so defibrillators are always programmed with a sensitivity that is much more sensitive in the ventricle than our pacemakers. Okay, so in this case, we would just go with the default one that the manufacturer gave us. Might not be right, by the way. It's always a concern, always a risk, but that's what we would do. Okay, this will be our last one today. This was shown to me by one of our astute fellows, and they were shown this by the floor team, and they wanted to know whether we agreed that this was, as you see, the computer says it's VTAC. So let me ask Dr. Bebbia what he thinks about this.
Good morning. It looks like an artifact from my first impression. And I'm saying that because I see the QRS complexes marching through, that I could kind of.
I agree. This was an easy one, actually. But yes, this is pretty clearly an artifact that the computer is misreading. Since you did that so quickly, we'll do one more. This one is saying that this is ventricular ectopy, the starred complexes. Do you agree, Dr. Bebbia?
Do I agree? So I see from the beginning, and I assume that all these leads are simultaneous.
Mm-hmm.
We see a P wave and a QRS, a T wave, and then we don't see a P wave, and we see a QRS complex that's different from the prior one, which is either and it's a narrow one. So I think it's probably some kind of a junctional, well, not actually junctional. It's more of a, because if it was junctional, it would be the same. So I guess that would be PVC, although it's strange that it's so narrow.
Do you see anything before each of these complexes? Look in the lead, what they call lead 3.
Oh, down below.
Mm-hmm.
So there's a tiny blimp after the T wave with a long kind of, if we think it's a P, then there's a long PR.
Mm-hmm.
Then we have a then we have either a pause or a blocked PAC, again buried in that T wave. So it looks like it's and then I see. So I think in the beginning it's probably atrial bigeminy,
Yeah,
and then
I think it is. I think it's atrial bigeminy throughout.
right, and then it's just curious why this QRS complex looks different from the other ones.
Well, that's a good question. Is there anything
Maybe-
about the timing of the A to A interval on that beat versus the others?
I guess maybe there is some aberration.
Right, this
Yeah, so it's
right, this P wave relative to this QRS, this interval is shorter than this interval. Right? A little bit, not a lot, but a little bit earlier.
true.
Right. Notice the difference. Look, notice how much isoelectric time there is between the T wave and the next P wave here, and between the T wave and the next P
shorter.
wave here. So, right, when we get more and more premature with atrial contractions, we get decrement, right, in the AV node, and we get decrement in the His-Purkinje system, right? That's a normal feature of conduction, right? Whenever we do atrial extrastimulus testing, we get earlier and earlier, and we see the PR or the AH interval lengthen. And there's also a little bit of HV lengthening as well, but we don't measure that because the His-Purkinje system decrements a little bit less or a little slower than in most patients than the AV node. But so it's interesting. This is fairly premature, and the QRS is definitely a little different than the sinus beat before it. This is kind of a similar degree of prematurity. And then this P wave is quite a bit more premature than, say, this one. And on that one, we get a lot more widening of the QRS. We also have a longer PR interval, and it's similar to this one as well. So I think this is atrial bigeminy with variable types of conduction. So this is actually probably our aberrated beats. So these are not actually PVCs. They are aberrated PACs, I would say. Does that make sense?
Yep.
Okay. All right. I think with that, we'll stop for today. I hope all have a great day, and see you in Sinai in a little while.
Thank you.
Take care.
Thank you.